So my name is Corey Arnold. I'm a professor in radiology and a couple departments in the School of Engineering. I might be a professor in computational medicine. I'm not sure yet. Still waiting to hear from Eliezer on that. But so
we haven't decided.
depends on this talk, right? I, along with others, work in the Biomedical AI Research Lab, and we have projects across a bunch of different medical problems and modalities. We do a lot in radiology. I sound a little loud. A lot in pathology. We do some EHR kind of time series analysis as well. And then we have projects in mobile health. And I'm going to talk about examples from all of these domains. The first thing I'm going to talk about is in the area of prostate cancer, where we've done a lot of work over the last few years using machine learning. And why is prostate cancer a good area? Well, it's the second leading cause of death in men. The diagnosis is based on palpation, labs, imaging, and histology, so biopsies. And there's a lot of diagnostic and prognostic challenges. So distinguishing prostate cancer on imaging, so just getting an MRI of the prostate, is challenging, and it often leads to either over or under biopsying. Determining treatment based on a biopsy is challenging again, and I'll mention why, and it can lead to over or under treatment. On the histology side, prostate cancer is graded with something called the Gleason grading system. It goes from 1 to 5. 4 and above is considered serious enough cancer that you treat it. So if you have what's called 3+3 cancer, meaning the primary and secondary types of prostate cancer you have are 3, it's low risk, and you kind of watch it over time. Anything greater than that is considered worthy of definitive treatment, which could be a bunch of different things. And there's inter-rater disagreement between pathologists when it comes to grading prostate cancer. So you see one person one day and they could say, you need your prostate removed. You could see a different person the next day and they could say, you know what, you're fine. Let's just come back and look at you again in 6 months. And it's kind of a big difference to the patient, clearly. So what's the workup look like? On the radiology side, we do something called multiparametric MRI. This is an example here. It's like 3 series within a study, just different imaging parameters looking at different underlying anatomy and physiology within the prostate. That prostate's a little, I can't point with any of these things. That prostate's the little thing in the middle, right there. And this is graded on with a scale called PI-RADS. So clinicians in their move to become more quantitative have developed these numeric scales to rate suspicion of cancer. So radiologists use PI-RADS. It goes from 1 to 5, 5 being the most suspicious, 1 being the lowest. And then on the pathology side, we do biopsies. There's 2 types of biopsies that we do. This figure is designed to look like a bird's eye view of the prostate, so looking down on it. And the first type of biopsy that most men in this country will get is called systematic biopsy, and that's because the prostate's about the size of a walnut. And so in a systematic biopsy, you can do it in the outpatient setting with ultrasound guidance, and you just attempt to sample essentially the prostate equally over space, thinking you'll get a good enough diagnosis because the prostate's relatively small. At more specialized places like UCLA, we do magnetic resonance ultrasound fusion guided biopsy. And so what happens here is that with this real-time fusion of the ultrasound and the MR, the urologist can target the regions within the prostate that look suspicious for cancer. Okay, so that's good. You should get better diagnoses from that. And then, as I mentioned, when you pull out the tissue, the pathologist looks at it and they grade it according to the morphology of the glands that they see. Again, from 1 to 5. So the lower, less dedifferentiated glands are the more dangerous and aggressive. So biopsy is the gold standard, but there's some problems with it. First of all, systematic biopsy, as I mentioned, is the most prominent technique, but it is prone to error because it's essentially like a blind biopsy. These are a couple of types of the errors you can encounter, but essentially you're just missing the cancer, right? Either due to systematic or random errors. It happens around 35% of the time. So 35% of the time, your true cancer risk is higher than what the biopsy reveals. It's a lot lower in targeted biopsies, we're actually trying to get the region the radiologist saw, but most men don't get that. Okay, so if I'm a patient, what does this mean for me? I meet with my nice doctor, they tell me I have 3+3 prostate cancer, but we know there's ambiguity in that, and 35% of the time it's worse. So now I have trouble making a decision, right? I can do active surveillance, which means I can wait 6 months to a year and do another biopsy, which really wasn't much fun. Or I can do other things, androgen deprivation therapy, focal therapy. I can even get my prostate removed. And a lot of men do that just because it's uncomfortable, but you can live without it. There's a risk, but maybe they don't need to. And this is everything I just said. Okay, so something we've been working on is, can AI detect aggressive cancer earlier and hopefully more accurately? So the first modality we've looked at extensively is in radiology. I'm not going to go into too many details, but one thing we did early on was we said, remember I showed that figure that showed the MR with those cylinders in it. Those cylinders and the cylinders here represent biopsy coordinates because we do real-time needle tracking of the biopsy in the prostate. And so we can actually look over the thousands of procedures and tens of thousands of cores we've taken, and we can give it advice on the optimal way to sample tissue from the prostate, right? So basically, if the radiologist sees this, we suggest you biopsy essentially around that area as well as that area to get the best diagnosis and take fewer biopsy cores. Because we have that registration, we can do this was a project a summer student did, but basically they registered the needle path with the MR images to generate these sort of imaging biopsy cores. For each one of these, we have a corresponding piece of tissue, right, that the pathologist looked at under the microscope and assigned a grade. And so they simply said, can I do this imaging or kind of virtual biopsy? And so they trained a simple model to predict or to classify Gleason grades from these imaging cores, right? But it's kind of a simplistic approach because it leaves a lot of the surrounding and important tissue information in the imaging space on the table. So something else we and many others have done is in the top right there, trained UNet type segmentation models that work okay for localizing suspicious regions. The blue is the ground truth, and the red is what the model sees. Evaluating these things becomes kind of tricky because in the top right one in particular, you can see the model sort of focuses on what the radiologist saw, but there's a lot of false positives too that are kind of dispersed around. We've also trained kind of weak learning approaches. That's on the bottom right, and I'll talk about that one briefly. So what we did was we took a multiple instance learning framework approach here. And so we take the whole volume of the prostate. It's actually not that big because remember, it was just that middle portion of the MR. And then we turn it into 8x8x8 patches. And we train, actually we just do feature extraction on both of those things. So we extract features from each of the patches. We extract features from the global image. And then we incorporate an attention module on the patches so we can localize what the model is seeing or localize the model's suspicion given its prediction. And then we append these two feature vectors back together and render a Gleason grade prediction on the imaging, right? So if we look at performance of these, we typically get ROCs in like the 0.75 range, which is like, it's interesting, but probably not that useful. In medicine, we consider other metrics too beyond AUC because even if something has a low AUC or lower AUC, it could still be useful. So we have something here called a Frock curve, which is measuring how many false positive lesions we get per patient at different levels of sensitivity. And we can stratify that further by the actual aggressiveness of the tumor. So on the far right here, the darker line appears like the most aggressive cancer pathologically, and we can detect it with higher sensitivity and lower false positives per patient, which is good. It makes sense. They're much more prevalent on imaging. You don't really miss them. So moving on to what we've done in the pathology space. I know this, I'm getting tired of presenting these slides, but they're still cool for people who haven't seen them. So from radiology to pathology, there's sort of an order of magnitude of difference in data, right? So this is that MR image, it's 65,000 pixels in one slice. The prostate itself is only about 2,500. But if we extract the prostate surgically, scan it under a microscope, all of a sudden we have 25 billion pixels in one slice, right? Essentially, that's what it looks like at full resolution. If you were to zoom in all the way, that whole prostate T2 volume fits right in that little patch. CFAR10, the whole data set fits within those pixels there. And 100 of these equals the number of pixels within ImageNet, right? So, and we have 500, 1,000 of these cases, and each one has multiple slices. And that little video gives you a sense of the scale. So it's a lot of data. We have to, you know, we can't train models on the entire image. Obviously, we have to do patching somehow. And a lot of our existing pipelines kind of break down. Or we can generate these about every 2 minutes, because we have pretty fast slide scanners these days. So one of the first things we did was just to see if we could detect and classify cancer on histology images like this. And this is a nice, you know, this is sort of pre-transformer. It was a nice problem for multiple instance learning, in which we have, for the entire prostate, this is what we get clinically. And we have the label for the whole prostate, and sometimes, or sorry, for the whole biopsy core. And sometimes we have little markers from the pathologist showing where they saw cancer. What we can then do is we can tile this into different regions and train a model. So at the bag level, we know what the label is, right? Cancer or not, let's just say. But at the individual tile level, we don't know what the label is. But we know there's some tiles that are predictive of the bag level. And so again, we train this MIL model. This one's a lot like the last one, except it's at 2 different scales. So the first scale is we train it at 5x, so that's 5 times or 50 times what your eye sees if you were just looking at the tissue. We extract features, I forget what backbone this is. And again, we have an attention module. And we have because we have so many tiles, we actually have to do some clustering to sub-select tiles that are important based on their attentions. But what we do is we train this model first to detect cancer or not at this low level of magnification, right, 50x. And then we take the most suspicious tiles based on this clustering of attentions and zoom into 20x or 200 times what your eye would see, extract features again, and we do Gleason grade classification, so actually grading how aggressive the cancer is. These models work pretty well for cancer detection. They work as well as a pathologist, I'd say. There have been papers published showing that you could eliminate 80% of the biopsies that pathologists look at and maintain almost perfect performance relative to a pathologist. This is the confusion matrix we have for this particular model. You can see it's decent. Some things are, one off the diagonal. That's not really uncommon for humans either. If you got 5 people together, you would see a pattern similar to this. If we try to understand what the model's looking at, I can show you attention maps. You can make of them what you will. The ones I've cherry-picked here align pretty well with what the pathologist marked up on the slides. Maybe more interesting is if you look at TS&E plots of those extracted features at 5x and 10x, you see that each tile or each dot here represents one tile. And at 5x, we can separate cancer and no cancer. And then at 10x, on the lower right here, we can start to separate benign from low grade and high grade, which is what we'd expect a pathologist to do at that resolution. But these are actually 3D images, right? There's information across the z-axis here that the pathologist uses. It's kind of clumsy how they do it, but they are tracking glands through what is for them the z dimension, and that's important for diagnosis. So we were interested to see if we could train a model on 3D pathology images. And the first thing we had to do, though, was develop this alignment framework. So it's basically a key point alignment registration algorithm that's all affine. And basically, once we pass it through that, the biopsy cores are now aligned, okay? And so what that means is we can stack them up, right, and train 3D filters. So what we have here is a data set of around 7,700 biopsy cores. It's about 2 to 3 slides per core. And each slide has 2 to 3 ribbons of tissue, right? So we have up to 9 ribbons of tissue that need to be registered for a single biopsy core. And these are the breakdown of the classes in our train validation and test, if you're interested. So here we do a couple different things. I'm not going to go into detail on the methods, but we do on 3D, we have a Dino contrastive learning framework with a time-S-former backbone. On we have a 2D baseline where, again, it's Dino-based, and we compare those two here. So the time-S-former allows us to combine information across the ribbons, so for sort of a 3D thing. And basically, the differences are subtle but noticeable in that we can see that we do better, more hits on the diagonal with the ground truth, especially in certain areas that are important diagnostically. So Gleason grade 1 here versus 2 is kind of a decision point between treatment or not. And if we binarize on that threshold, we see that we do much better than the 2D model. So if we're in the process of putting together a paper on this, and we wanted to look at, well, what are the models looking at, in quotes, relative to one another? And here are 2 cases where they're truly high-grade cancer. The 3D model got it right, and the 2D model got it wrong. And the pathologist selected these regions as ones that were important to look at across ribbons. And so we visualize the attentions here. Again, we can kind of tell a story that we want to tell with these. But you can kind of compare the 3D model has some focus on regions that are of low interest to the 2D model. And so if I had a pathologist here, they could walk you through the slices in the volumetric patch and tell you what the gland was doing across the images and why it was important. But we were just happy to see differences in our case. So there's a lot of prostate biopsies that pathologists have to look at. This is what gets generated from a systematic biopsy. It's all these slides with these different cores. The pathologist has to put each one on the microscope, look at it, take it off, put the next one on, zoom in, try to find the same spot they were at on the last one to look at the gland through space. So there's 12 cores here. If you do targeted biopsy, there's 6 cores. These cases take them over an hour to do one. We do, 10 prostate biopsies a day. So they get kind of tired. They're always tired whenever I talk to them. So they're interested in solutions that make them faster, be it AI or something else. And so what we also looked at was taking these registered images and putting them into a digital viewer so that the pathologist can scroll through biopsy cores just like a radiologist scrolls through brain MRIs, right? And so this is actually what it looks like. Don't need to spend too long on this, but you can see these cores are now more or less aligned. We'll zoom in here. Again, it's a rigid alignment, which we don't want to distort the morphology, but it's still, with your eye, you can track the same location very easily in the tissue, right, and evaluate it. And so we did a reader study. We were only able to get 2 pathologists, but it's a good start. And essentially what I'm showing here is their agreement for each pathologist 1 and 2 between the microscope and their digital read. They did each case twice with a washout period in between. You can see there's differences between the same pathologist on the exact same cases with these 2 methods. That's not surprising to us. And then we did an inter-rater agreement between the two with the digital method and the microscope method. And statistically, what we found was that there was better agreement digitally than with the microscope, which is, again, what we hope to find. It's easier to interpret the images. It's more consistent. So that was a project that we're wrapping up now, hopefully. So moving on to some multimodal work that we've done recently that we're interested in multimodal. A lot of people are interested in multimodal in medicine. It's actually kind of hard to do because we usually deal with retrospective data that was collected for clinical purposes, and it's not missing at random. We don't have a lot of the data, so the more modalities we include, it seems like the fewer patients we have to analyze. Nonetheless, we still tried. So one big problem we have, I mentioned, there's a 35% upgrading rate following prostate biopsy, right? 35% of the time the cancer you have is worse than what was shown on biopsy. So we said, okay, can we predict surgical upgrading given pre-surgical data? So essentially, can we predict if your final prostate severity score will be higher on prostatectomy compared to biopsy? And we took a pretty simple approach here. We just used the features, essentially, there's some tweaks we made, but for purposes here, we basically took the features we extracted from the imaging to do cancer detection. We took the features we extracted from Dino-based features from the histology, and we trained a model to do upgrading. And then we appended those together with clinical features, so age, ethnicity, lab, PSA is a lab value. And we then joined those together and trained a model to do upgrading. So we had 214 cases at UCLA in our test set, and about 15% were upgraded. These are our single modality results. You can see, not surprisingly, that pathology does the best. There's kind of the most signal, I think I would argue, for this particular task in pathology. And if we look at different combinations of the clinical, the different modalities, clinical radiology, et cetera, we find that using all three together does the best in this rightmost column here. And again, ones that include pathology do better. So there does seem to be some complementary signal between these different modalities. I would argue that we probably need more data, both internally and externally, to validate and understand what's going on. There's some confounders to this. Men with negative or low-grade biopsy don't move on to prostatectomy, so they're actually not represented in our data set. And then another confounder is time. So it is quite possible that you could have a biopsy that is truly low-grade, but by the time you have a prostatectomy, it's evolved into high-grade, meaning that it wasn't high-grade at the beginning. So that's a potential problem. So a way to maybe deal with these is to see if we can find markers of high-grade prostate cancer from normal or low-grade prostate cancer in the same specimen, okay? So essentially using what's been referred to as cancer field effect to find misdiagnosed cancer. And this concept is pretty simple. Again, there's our prostate. Looks a little different from this angle, but you can see the cancer in white there, and the biopsy cores we've taken, and we've kind of missed the cancer in this case. But if we presume that, as the figure on the right here shows, that cancer is exerting some kind of effect on the surrounding tissues, maybe we can pick up that it's there based on, even though we missed it, based on what a pathologist would say. So this field effect has been studied, at the molecular level. It's been shown that cancer does have an impact that's detectable. On the histological, sort of morphological level, is kind of an open question. So we can formulate this as a machine learning problem. This is one of our whole mount prostatectomy specimens. We have the region that's cancerous that the prostate, or the pathologist outlined here, and we can digitally segment that, and then we can identify regions far away from that we know are benign, that the pathologist has told us are benign. There's a little bit of a caveat there, like if they can't detect morphological changes because of the cancer with their own eye. How do they know it's benign? So we have some ways to try to get around that issue. But basically now we have sort of this two-class problem, right? And we're only going to look at stroma. That's sort of the supportive tissue for the glandular tissue within the prostate. I can talk about that offline if you want. But so our positive class is going to be stroma within the cancer. So this should be the most changed because of the cancer, right? And our negative class is going to be stroma far away from the cancer. This should be the most normal-like. And our idea is to do this in whole mounts, that's shown here, and then move it to biopsies where it would truly be useful. So if we look at some pathomic or kind of handcrafted engineered features from these two regions, we do see a difference across many of our features. And when we train a model, so we extract UNI features. These are our self-supervised features from a lab run by Faisal Mahmood at Harvard. But basically, they're trained on large or learned from a large collection of histology images. So we can extract those, train just a 2-layer MLP, and then classify tumor-affected stroma versus not. We have about 350 RPs at about 400x magnification, and we do surprisingly well, right? Like almost too well, that we see these results and we think, no, something's probably wrong. If we look at heat maps of how well it works, trying to understand what's going on the top we have an aggressive cancer, and we detect a lot of reactive stroma. On the bottom we have a low-grade cancer, 3+3, and we don't detect a lot. So, I mean, this is just two examples. We need to dig a little further. If we look at high confidence predictions of non-tumor-affected stroma and tumor-affected stroma, here are some examples. Are there any pathologists here? No. But basically, when I have shown this, I can see it a lot better on this monitor. When I have shown this to pathologists, they are able to see sort of subtle changes in collagen and nuclear density in terms of the color and the size that's known to be inflamed. But again, we need to do more work with kind of humans reviewing this stuff. So the plan is to move this to biopsy. We're going to have to do more training, obviously, with biopsy samples. We'll do inference on test biopsies. You can imagine ways we might do that, given that we know the biopsy coordinates, we know where the cancer is. We can look at near and far away biopsy cores. Results coming soon. Okay, so that's the radiology and pathology stuff in the prostate space. I wanted to touch on two other projects that are pretty cool, I think, that we've been doing that are a little more recent. One is in EHR modeling. So I think Jeff Chang talked a little bit about the data set we have in this yesterday, but we have about 2.4 million patients at UCLA who got some kind of care here. Data is structured according to OMOP, which is like a standard representation for clinical data. We split it for our experiments that I'm going to talk about here into training and test sets of 80 and 20%. So 1.7 million versus about 430,000. One thing we did that I emphasized was I wanted to say, often when you write papers, you get dinged if you don't have an external validation set, sort of rightfully so, sometimes maybe not others. But what we said we were going to do is we were going to train the model with data prior to 2022, and we're only going to test it with data afterward, right? So kind of trying to simulate a prospective evaluation of the model. Our data is ICD-9 and 10, CPT codes, RX norm medication codes, and LOINC codes. These are laboratory diagnostic codes. And so our final vocabulary, which was reduced based on frequency and some other things, is about this, 1,200 diagnostic codes, 17 medication codes, et cetera. Okay. So this is what the data looks like. So we have a patient, they have an age, they have a sex that's known, and then they have a series of visits to one of our clinics. This could be outpatient, urgent care, hospital visit, et cetera. And these visits all contain codes. They have a visit type. They have those codes I just mentioned. And they could have a discharge type. So if you're in the hospital, you'll have a discharge type where you discharge to your house, to hospice, did you die in the hospital, et cetera, that's captured in this code, okay? And we also include a time token to try to impose some temporal information on this process, some relative differences between when these visits occur, okay? So the time token is, it's basically, it can take 4 values. It represents the time between visits as 3 months, 3 to 6 months, 6 months to a year, or more than a year. Okay. And this is what we've done. So we trained a GPT-2 model because it fits on our GPUs and is small enough with the training data, the 1.7 million roughly patients. And then we use that model to do zero-shot prediction of kind of everything. I think we selected maybe 32 diagnoses of interest that have been done before. But essentially, so how it works is we do 128 tokens to prompt the model. And then we mask, 3 months, or we allow the model to generate, but we don't take any of those codes for 3 months because we want to give ourselves a window. It's not very useful if you predict somebody's going to have depression tomorrow, essentially, right? If you predict it 3 months out or 6 months out, that might be more useful because you can actually intervene. So in our decoding, it's a greedy-based approach, meaning we just take the most probable token at every next step and generate the next token. And then we're looking for our token of interest. So F32 is the diagnostic code for depression. Diagnosing depression is not as simple as one code, despite what many papers have reported. It's like a constellation of things, but we wanted to compare to what others have done. So we keep predicting between essentially 3 to 12 months out based on our time token until we get over a year or we run out of tokens to predict given the model. So if we look at zero-shot prediction of heart failure, again, this is in a cohort of patients post-2022. So none of their, temporally, they're distinct. You can see how we do. So top 1, top 5, top 10, top 20 just refers to in the distribution over predicted codes at the next emission. If we use top 1 only, this is the performance we get. If we say, okay, any code in the top 5 we'll take, that's what we get, top 10, top 20, et cetera. So not surprisingly, you can see as we start taking more codes, we start doing better in terms of detecting people with the condition, but we also start generating more false positives, right? But not, it's a balance. You have to think about how you're going to implement a tool like this. If you use it for, screening, targeted screening, or if your intervention is as simple as a phone call, you can tolerate false positives, right? This is end-stage renal disease. Again, you can kind of see differences in metrics here. Same general theme. So we're in the process of evaluating this over, I think I said 36 different diseases and outcomes, all kind of without any fine-tuning. If we look at the embeddings for the different codes, all of them that I mentioned, these codes are all pulled from hierarchies, right? And so these hierarchies have classification schemes, so we can aggregate these codes under them, and we can just kind of look at and see how these codes cluster together in a UMAP representation, which is good to see. There is some overlap with certain codes, which makes sense. Some codes go across different diseases, right? So depression goes across cancer, autoimmune diseases, other things. So you might see that code closer to those other diseases. Okay, one last project, mobile health. This one's short, but I mentioned it. So something we did not long ago was trying to predict patient-reported outcomes for ischemic heart disease patients. So we said, okay, we're going to give you an activity tracker, and based on the signals generated from that device, steps, heart rate, et cetera, we're going to predict your underlying disease state. So we can send you home, and all you got to do is wear this thing, and we can tell how you're doing, right? And if we sense that you're entering a dangerous state, we'll give you a phone call, or we'll tell you to go to the urgent care or something like that. So our first study was with 182 patients from Cedars-Sinai with ischemic heart disease, and we had 12 weeks of activity tracker data. And each week in the study, the patients completed a patient-reported outcome called PROMISE. It's a validated measure that looks at like disease burden and functional ability for individuals. And so essentially the machine learning setup was input activity tracker data, train the model to predict those weekly PROs, right? These are some of the data points we got from the Fitbit, stuff you guys are all familiar with either Fitbits or Apple Watches. The PROs were from an NIH repository called PROMISE, and basically they're kind of a little weird to read, but on the symptom scale, having a low value is good, and on the function scale, having a high value is good. It's nice because you can binarize the scales based on what the developers of the instrument determined. So we trained a model to predict, I think, moderate and severe versus normal and mild. This is a paper from several years ago. Our best performing model was a random forest. You can see we do okay in terms of AUCs. I don't know what the data balance is here. I think it's close to balanced. But it's not surprising, stuff like global physical health, we do the best at because that correlates pretty well with like steps you're taking. But then stuff like anxiety, depression, you might imagine there's correlates, like maybe I take fewer steps if I'm depressed, but it's not strong enough that we could detect it kind of robustly. One big problem we have with this kind of intervention though is, and this is what's been shown in the literature a lot, is that with time, adherence goes down, right? I think we can all appreciate that in one way or another with something in our lives, a new exercise regimen or something. But so we're interested, and especially with devices that are kind of a pain. So some of the earlier studies made you put on like a blood pressure cuff that had a modem in it, right? And you would take your blood pressure and then you'd have to do something to send the result to the study center. But our thinking was Fitbits, wearing a watch is about as easy as it gets, but still not everybody wanted to do it. So we had a grant to develop a solution that might increase adherence to home monitoring. And so we had a study with 3 arms. The first arm just had a Fitbit and a scale. The second arm had those 2 things and a mobile app. And the third arm had that stuff, and you got money, right? Nothing motivates like money. If you're talking about the world of heart failure, if you give somebody, $1,000 a year for being adherent, and that saves them 2 trips to the OR, or the urgent care, the ER, you're saving money, and a lot of money if you're a payer, right? So our primary outcome here was adherence rate, and we currently have 250 people enrolled. This is the actual app we built. This was an interesting process, trying to figure out what people want to look at. Basically, there's a couple different screens. This is your home screen. It's sort of like your overall stats. Have you synced your Fitbit today? Have you weighed yourself today? And have you answered 3 questions? Each day we ask them to answer 3 questions about their symptoms. Did they take their medication? And did they eat their diet that they were supposed to eat? So that gives us some dependent variables that we can predict later on, we hope. Surveys, they level up. We tried to do some gamification. So the more adherent you are, the higher the level you get. And in arm 3, the higher the level you get, the more money you get. These folks get $150 over 6 months. And then we also wanted to incorporate gambling, because everybody likes it. Not gambling, a game of chance, okay? So we incorporated a Wheel of Fortune-like feature for those who know the not Wheel of Fortune, look at me. Price is Right. There you go, right? Price is Right. So at the end of the week, you get to pull the Price is Right wheel, and you get an award that's commensurate. This could be cash that reflects how adherent you were during the week, okay? So if we look at early results from 111 patients, this is our adherence over these 180 days of follow-up by the different groups, devices only, devices and app, devices, and financial incentive. What we found, to sort of summarize this, is statistically significant differences between the finance group and the baseline group, just the devices for both weighing and wearing the Fitbit. And then between the adherence group, or the app group, and the app plus financial incentive group, differences as well, but not really significant across the board. But one other thing, sort of these levels of adherence at 180 days, so maintaining, for the Fitbit around 75 to 80% adherence is actually pretty high. And adherence is defined as wearing the device, I forget what the threshold was, but it's something like, it's syncing it every day, right? And having heart rate measurements indicating that you're wearing it. I forget exactly how we broke it down, but I can look at the paper. So the next steps here are, well, we also did some correlation analyses, and we found significant correlations between activity and self-reported symptoms. So that was like, how much did heart failure affect your life yesterday? That correlates with how many steps you're taking, not surprising. And the current work is to develop models once we get more data to try to forecast heart failure exacerbations. So with that, thanks for listening. Thanks to everyone on the team and all their work. Appreciate any questions.